Usage of steroids in the management of COVID-19. The World Health Organization, Centers for Disease Control and Prevention, and Infectious Diseases Society of America have recommended the usage of corticosteroids in severe COVID-19 patients who require supplementary oxygen. Corticosteroids help in controlling the hyperinflammatory state caused by cytokine storms produced by the COVID virus. The extensive inflammation may lead to complications such as acute respiratory distress syndrome, clotting, hypotension, shock and death. However, systemic corticosteroids should be avoided for patients with mild or moderate disease who do not need oxygen support, unless there is another indication. The recommended corticosteroids are dexamethasone or other alternatives like methylprednisolone or prednisone. Dexamethasone and methylprednisolone are the preferred corticosteroids for the management of COVID-19 in critically ill patients due to their high bioavailability. Both oral and intravenous routes provide high bioavailability of dexamethasone. In case of intestine dysfunction, systemic corticosteroids are administered intravenously. Dexamethasone is the recommended corticosteroid for the management of COVID infections as it exhibits the highest glucocorticoid activity. Low doses of dexamethasone have shown significant reduction of mortality in COVID patients. Methylprednisolone is a quick-acting corticosteroid when compared to dexamethasone for the management of COVID infections. There are decreased chances of long-term side effects with methylprednisolone for the management of COVID infections. The daily recommended dosage of dexamethasone is 6 micrograms per day. Other alternatives for dexamethasone are prednisone, methylprednisolone, and hydrocortisone. The doses of these alternatives are given here. Currently, corticosteroids should not be administered for more than 10 days. Continuation of corticosteroids should be considered only for severe cases. Long-lasting course of corticosteroids can inadvertently lead to poor treatment outcomes. Protracted corticosteroid therapy might contribute to the so-called long COVID syndrome that manifests with fatigue and psychological symptoms, in which steroid-related adverse drug reactions such as myopathy, neuromuscular weakness, and psychiatric symptoms might have a part to play. Prolonged usage of steroids may increase the risk of reactivating latent infections. Moreover, there is no evidence that long-term usage of steroids prevent complications such as pulmonary fibrosis. Prolonged use of corticosteroids along with adverse drug reactions contribute to the increased mortality rate. Fungal infections such as mucormycosis have been reported in COVID patients, particularly diabetics. Factors that increase the risk of mucormycosis include use of steroids without indication, self-medication by home-isolated patients and use of a higher dose for a longer period of time. Hence, it is extremely important that steroids are used judiciously and only when indicated. Doctors must closely monitor patients when they are on systemic corticosteroids as they can have side effects. The side effects of corticosteroids may include secondary infections, hyperglycemia, avascular necrosis, etc. Proper history of medications must be taken as corticosteroids may also have potential drug interactions with some medications. In cases of prolonged use of corticosteroids, abrupt cessation can precipitate a flare of underlying conditions. The most feared complication of corticosteroid withdrawal is the suppression of the hypothalamic pituitary adrenal axis, which can result in secondary adrenal insufficiency. Hence, wherever possible, short-term use of corticosteroid must be preferred. For cases where corticosteroid is used for more than 14 days, the dosage of the medication should be reduced gradually.